Hello, I am Karlene Lawrence, the co-director of the interprofessional teams, which is part of the HRSA Bridge GWEP grant on our service. I am presenting comprehensive geriatric assessment for the older adult. The HRSA Bridge grant that we received on our service is to educate the next generation of healthcare providers to provide interprofessional, geriatric-friendly, age-friendly, and dementia-friendly care. I don't have any conflicts of interest. This presentation, Comprehensive Geriatric Assessment for the Older Adult, is part of our Curriculum A series. Commonly used acronyms that I may use throughout the presentation, which I did already, is HRSA, which is Health Resources and Services Administration, GWEP, which is Geriatric Workforce Enhancement Program, Bridge, which is a Brooklyn initiative to develop geriatric education, the 4 M's, which I'll explain later, the Bridge IT, which is interprofessional teams, which is, as I said, we're trying to educate the next generation of interprofessional providers to be age-friendly, geriatric-friendly, and dementia-friendly. And SLM, which this is a part of, is a self-learning module. The learning objectives for today, for this SLM presentation, is to define the diagnostic and treatment process of a comprehensive geriatric assessment. Identify the components of a comprehensive geriatric assessment, which I may also refer to as a GCA. Discuss the best evidence for performing a comprehensive geriatric assessment. Identify the content on which a comprehensive geriatric assessment is dependent, and identify at least 5 criteria that determine which patients would benefit significantly from a comprehensive geriatric assessment. The 4 M's, which I mentioned before, our grant is based on this format. It's a cooperation between the Hartford Foundation and the Institute of Health Initiatives or Improvement. It's based on 4 principles that we assess all of our patients, our community residents. I may use those 2 interchangeably. The first is what matters. We actually ask patients what matters to them. And sometimes they are so taken aback by a provider asking them that they have no response. But we provide patient-centered care, and what the patient prefers or what matters to the patient and or their family and caregivers matters to us, and we incorporate that into our assessment or encounters with them. Another of the 4 M's is medication. So we assess at every visit a patient's medication. We do a medication reconciliation because that impacts also what matters to them, because it may affect the next 4 M that I'm going to mention, which is their mentation. We also assess that at every visit and may also affect their mobility and keeping them independent at home, aging in place in the community. So throughout the presentation, I'll have some ageism alerts. We're trying to stamp out ageism, as I said, to provide dementia-friendly, age-friendly care. So the first ageism alert that I would like you to think about is negative stereotyping of elders is one cause of ageism, and negative preconceptions related to aging are directly related to poor patient outcomes. A comprehensive geriatric assessment is an interprofessional diagnostic and treatment process that identifies preventative, psychosocial, and functional capabilities of older adults to identify treatable health problems, develop a coordinated plan to maximize their overall health for better outcomes. The components of a comprehensive geriatric assessment all come together to determine the patient or the community resident's functional status, and then that is their medical conditions, what may affect that, support services, social support, psychosocial support, their spirituality, their economic status, the environmental status that they live in or their neighborhood is in, and their cognitive status. And that all comes together to impact their functional status. The structural approach, so a comprehensive geriatric assessment has 2 major structural approaches. The first is multidimensional, which is the physical health, their medication and pharmacy, one of the 4 M's, their cognition, again, one of the 4 M's, which goes with mental health, their functional ability, their psychosocial environments, their psychosocial conditions, and their socio-environmental conditions. There's also the other major part of, or other major structural approach to a comprehensive geriatric assessment is interprofessional. Geriatricians, physicians, physician assistants, nurses, all specialties come together to ensure positive patient or community resident outcomes. The geriatrician or psychiatrist would be involved in nursing, as I said before, NPs, nurse practitioners, RNs, and social workers, nutritionists, physical therapy, occupational therapy, definitely caregiver and family support, and spiritual and religious support. A comprehensive geriatric assessment can be performed anywhere. In the home, as we're doing right now with remote or telehealth patient visits. In a healthcare facility, which is acute, which would be inpatient care or outpatient clinic or department. At a community or a senior center, an adult day program, a skilled nursing facility, a long-term care facility. So as I said, it could be performed anywhere. The content of the assessment varies and is dependent on the healthcare setting. The best evidence or reason for a comprehensive geriatric assessment is identifying appropriate individuals or patients or community residents who would derive the most benefits from having a comprehensive geriatric assessment. The qualifying criteria for a comprehensive geriatric assessment is identifying factors for individuals, as I said, who would significantly benefit from a GCA. And that includes their health or medical comorbidities, for example, heart failure, diabetes, high blood pressure, whatever their diagnosis may be. Their psychosocial disorders, which is either depression, isolation, food insecurity, housing insecurity. Specific geriatric conditions, example, their age, their mental condition, or if they have dementia, which would or could predispose them to falls, or their functional status, functional disabilities, which will include their ability to complete their activities of daily living or their independent activities of daily living, which I will address later. Changes in their living situation, for example, going from independently living in the community to living in an assisted living facility, requiring in-home assistance from, for example, a home health aide, or being admitted to a long-term care or a skilled nursing facility. Inpatient referral factors for a comprehensive geriatric assessment includes referral for preliminary screening to determine whether a full interprofessional evaluation is required. Older adults admitted to a medical or surgical, for medical or surgical reasons, example, fracture, failure to thrive, whatever brings them into a healthcare facility, recurrent pneumonia, pressure sores, etc. Individuals age 65 years and older, actually older adults, which is what we're calling our seniors now, instead of saying geriatric or seniors, is defined as an adult 55 years and older, and a senior is starting at age 65 years and older. So individuals who score high on a threshold of screening that's predictive of hospital readmission. So there's various screening tools that we use, which I will cover later on, and depending on how they score, high or low, normal or abnormal, would indicate whether they require further assistance, whether they could continue to live on their own in their homes in the community, or whether they should be admitted for inpatient assistance or inpatient continuing care. Outpatient referral factors for a comprehensive geriatric assessment include individuals with multiple health issues or problems identified during a geriatric screening assessment, individuals with major illnesses that require hospitalization, or increased home resources to manage medical and functional needs, specifically, as I mentioned before, their functional status, their fall risk, their cognition, or if they have mood disorders, have been diagnosed with mood disorders. The comprehensive geriatric assessment outpatient exclusion factor. So we would not assess patients for a comprehensive geriatric assessment that have a terminal illness, severe dementia, a complete functional dependence, so they're not independent in their home. They may be in home, but they have assistance and they're totally dependent on the assistance to complete their ADLs or their IADLs. Inevitably skilled nursing facility or long-term care placement. So they're currently may be outpatient living in their homes, but imminently they will be admitted or recommended to be admitted to a skilled nursing or nursing home or assisted living facility. And these individuals are generally deemed unlikely to benefit from a comprehensive geriatric assessment, and therefore they're excluded. This, along with the ageism alert, which I mentioned before, I also have what's called brainstorms. These are little questions that I pose that I give you an opportunity to think about and come up with an answer, or just learning something new that we want you to be aware of as part of our grant, as part of our interprofessional training. How can healthcare providers learn to recognize our own implicit biases, stereotypes, and misconceptions about older adults? We need to be aware of these to provide better care, to provide age-friendly, dementia-friendly care to our older adults or community residents. A comprehensive geriatric assessment should include assessment. So should include assessment of functional capacity, again, their ability to complete their activities of daily living by themselves or with assistance or with supervision. Also their independent activities of daily living. An assessment of their fall risk, their cognition or their mood disorders or lack thereof. Polypharmacy, which I'll cover also in a little bit. Their social support, their caregivers, their finances, their care goals. So care plans, care goals, what's, again, coming back to what's important to the patient, what's important to the community resident, what's important to the family. So their care goals. Advanced care preferences and directives. So at every visit, we should have a discussion with our patients, with our caregivers about advanced directives. A lot of families wait until it's too late when the patient or the community resident does not have the capacity to consent, to give written or verbal legal consent to determine who their healthcare proxy will be, to set up a live-in will, to set up financial powers of attorney, to determine who will take care of them when they can and who will speak for them when they cannot speak for themselves, especially in a healthcare setting. So that's a discussion that we have with our patients and caregivers earlier on, and advise them, as uncomfortable as it may be, to have that discussion with their family, with their caregivers, and establish that as soon as possible. A comprehensive geriatric assessment may include assessment of vision. May include vision, hearing, which we actually recommend as part of our service because sensory deficits, vision and hearing, affects cognition sometimes, affects memory, affects mood, and affects the person's ability to function independently. Speech, dentition, how are the dentures fitting? They have them, but they won't wear them. They take them out to eat. Nutrition, are they eating properly? Coming back again to food insecurities, are they able to afford a complete, well-balanced meal at least once a day or more, hopefully? Their weight, are they gaining weight? Are they losing weight? Is this voluntary? Is this involuntary? Are they trying to lose or gain weight, or they're just losing weight because of other medical conditions, or they're not able to eat properly? Their gastrointestinal, their GI tract, stomach from mouth all the way down, and urinary, definitely sexual function, their living situation, and their spirituality. So a comprehensive geriatric assessment may include assessment of, but a couple of these I think should be included in a geriatric assessment. A comprehensive geriatric assessment starts head to toe, past medical history, history of present illness, their health, the ANP-C, history and physical, cognitive capacity, neurological screening or assessment, ears, nose, mouth, throat, respiratory assessment, so hearing, as I said, vision, sensory screenings, their functional ability, medication reconciliation every visit, every time, and we are asking the patient to tell us what they have. We may have it on our electronic medical record from the last time we did a reconciliation, but every visit we ask the patient to tell us. If they can't pronounce the names of the medication, we have them spell it, what's the dosages, the milligrams, micrograms, units, and what's written on the label as far as the interval. From doing medication reconciliation, a lot of patients or community residents or caregivers realize that they're actually not taking the medication at the right dosage or the right interval that they thought they were supposed to be. So medication reconciliation, every visit, we're asking the patient to get all of their medications together and come and tell us what they're on. We're not telling them what we have on our system. Nutrition, gastrointestinal, genitourinary, musculoskeletal, balance, most important, gait, fall risk assessment, and prevention, teaching for prevention, bone integrity or risk for osteoporosis, or strength assessment, or sarcopenia, incontinence assessment, are from urine and fecal, so bowel and bladder, psychosocial, environmental, and social assessment. And again, most importantly, their functional status. Neurology and endocrine assessment, hematology and immunology assessment, infection prevention, preventive health and wellness, spirituality and coping, and family leisure pleasure activities. Also, as important and sometimes overlooked is sleep hygiene. How are they sleeping? If they're getting up every hour to go to the bathroom, they're not getting quality restful sleep. Mental health, most important, one of the 4 M's. Are they having panic attacks, anxiety, depression, suicidal thoughts or intent? Their mentation, life stressors, what's happening in their psychosocial environment, what's happening in their homes, their relationships, their sexual health, employment and finances, their family dynamics. Are they the caregiver for everyone? Have they taken in their children's children? Are they the primary caregiver for their grandchildren, which is increasingly happening? Blended families, domestic abuse, emotional and verbal, physical abuse, neglect, or abuse and violence. The comprehensive geriatric assessment also includes an assessment of eating disorders, hopefully to identify if they're eating disorders. So again, coming back to food insecurity, are they losing weight because they plan to lose weight, or they're losing weight because they have a mental issue that makes them think they're overweight, so they're not eating, or they just can't afford food to eat a nutritious meal. Laxative abuse or use, and bulimia. Excuse me. Cigarette, alcohol, and illegal or illicit substance use or abuse. Support system, family, which include family, friends, teachers, clergy, whoever is there for you. I have patients who their healthcare proxy and their support is their neighbor, and I think that is very amazing of the neighbor. Coping ability and mechanism, counseling and referral as indicated, most important. I have a brief video that I'm going to play about a comprehensive geriatric assessment.
When they are able to function, people can age in a good way. As they get older, people often become ill with chronic long-term illnesses. Their ability to function begins to deteriorate, and gradually, problems with their functional ability emerge. As their state of health and functional ability deteriorate, elderly people are in increasing need of health services. Multi-illnesses can result in the need for extensive treatment and rehabilitation. Elderly people themselves want to be able to live in their own homes for as long as possible, able to function and healthy. The system of services should develop effective ways of working to assess the health and functional ability of elderly patients, as well as their rehabilitation and ability to live independently. Comprehensive geriatric assessment is a multidisciplinary endeavour. The assessment focuses broadly on factors that weaken functional ability. Based on this, the patient's true need for treatment can be defined, and the care and rehabilitation plan can be made. Assessment of different areas of the patient's state of health and functional ability generates quality care that is patient-centred. Assessment reduces the number of treatment days in the long term, and in this way, treatment costs can be brought under control. The comprehensive geriatric assessment comprises medical assessment. The medical assessment is done by a doctor. Assessment of functional ability. Functional ability is assessed by a physiotherapist. Nutrition assessment. A nurse takes care of the nutrition assessment and health measurements. Assessment of care and rehabilitation. The planning and assessment of care and rehabilitation are done in multi-professional teams, comprising a doctor, nurse, and physiotherapist. The teams may also include an occupational therapist, psychologist, and social worker. The patient's state of health and functional ability are assessed extensively, also taking into account the environment in which the patient lives. The patient's own resources are mapped, and these are supported. The patient's motivation with regard to self-care and living independently are of particular importance. Training provides healthcare professionals, doctors, nurses and physiotherapists, and social workers with an understanding of the significance of comprehensive geriatric assessment, its content, and the planning involved. After training, participants are able to assess the feasibility of comprehensive geriatric assessment in their own organisation. For more information, please go to www.savonia.fi.
So I'm going to go through each of the 4 M's, which is part of a comprehensive geriatric assessment. I'm going to start with polypharmacy. So polypharmacy is identified or defined as taking 5 or more, sometimes 4 or more medications daily. So you're required, or you do take 4 to 5 or more medications daily. And this is any combination of prescription medicines, over-the-counter medications that you may have bought yourself, or that healthcare provider may have recommended that you use, nutrition and herbal supplements. So it's everything that the patient is taking, whether they consider to be medicines or not. Diagnosis of multiple chronic comorbidities requiring concurrent use of multiple medications, being prescribed more medications than is necessary. Increasing use of multiple medications is associated with increased healthcare costs and increased potential for dosing adherence issues or misdosing, incorrect dosing, or medication interaction. The goal, why we do medication reconciliation at every visit, every time, is to assist the patient to de-prescribe if possible. If they're taking 3 medications to treat one condition, we could cut it down to 1. Or also, sometimes patients are taking medication that they have no idea why they're taking that medication. They've been on it for so long, they started it and they never stopped. So that would be something to speak to them, educate the family, educate the patient, the community resident, and take that off. So that's de-prescribing, is trying to cut down and, just as I said, decrease the possibility of having medication interactions and also having adherence issues or major adherence problems. However, while we're trying to de-prescribe and cut down medications, we should never under-prescribe for older adults because we think that they would not derive benefit from this medication. We should always attempt, if it's medically necessary and the literature supports it, start with the adage that we use: start at a low dose and titrate up slowly and assess for interactions or for adverse reactions. Okay? Adverse effects of polypharmacy is associated with increased use of multiple medications, as I said before, higher healthcare costs, increased risk and actual medication to medication interactions, medication non-compliance, and medication to illness or disease or diagnosis interactions. Development of worsening multiple geriatric syndromes, and that's covered in another SLM by one of our other providers. Providers should reconcile, as I said before, all medications that patients or community residents are taking, including prescriptions, over-the-counter medications, nutrition, herbal supplements at every visit, every time. The 2019 updated Beers criteria for potentially inappropriate medication use in older adults is similar to the one that came out in 2015. It includes the same 5 main categories as the 2015, but I think the age range is a little bit different. And number 1, the 5 main categories of the 2019 updated Beers is to identify potentially inappropriate medication in older adults. 2, potentially in those that we identified, they should be avoided in older adults with certain conditions. It should be used with considerable caution in older adults. Combinations that may lead to harmful interactions should be identified and hopefully eliminated or limited use. And a list of medication that should be avoided or dosed differently for those with poor renal function. So those are the criteria covered under the 2015 and now updated 2019 Beers criteria. The other, another of the 4 M's that I'm going to address is mobility. And as I said before, each of the 4 M's interact with the other 3 M's. So as you could see, if there is polypharmacy or dosage adherence issues with the older adult, is actually going to affect their mobility. So this is where we assess for functional status. And the functional status is the most important determinant of quality of life for older adults. Independence in performing their ADLs includes the related concepts of functional capacity, which is an individual's ability to perform normal daily activities, fulfill usual roles, and maintain health and wellness. And functional performance, a self-report, so they tell us, that measures an individual's ability to perform and complete their activities of daily living. There are a few screening instruments that are used to assess patients and community residents' functional abilities, and deficits in their ADLs, their activities of daily living, or their independent activities of daily living can signal the need for more in-depth evaluation of the patient's socio-environmental circumstances and the need for additional assistance. And I'm going to cover a few of those. Excuse me. You should be seeing right now the CATS index of independence in activities of daily living. And this is a 10-point scale of self-reported. We ask questions and the patient tells us what's happening with them. And a score of 6 equals high. A patient is considered independent. And a score of 0 or up to 5 is considered low, or maybe the patient is dependent or requires supervision or assistance in their activities of daily living, or their IADLs also. The Bartlett's, which you should be viewing right now, Activities of Daily Living Index Scale. consists of 10 items with a combined maximum score of 100 and 100 being high or normal. And it's similar to the cats. We're assessing their ADLs, which is ability to feed themselves, bathe themselves, groom themselves, which includes selecting the appropriate clothes for the season and actually putting those clothes on, which is next is dressing. Their bowel habits, do they have chronic constipation, IBS, anything else that's happening with them, and are they able to toilet themselves? So that comes into toileting issues. Are they able to go to the bathroom on their own, or do they have to wear adult underwear, or do they require assistance when they go to the bathroom, they forget to wipe or they forget to flush? So this is a screening test for that. This is also includes urinary incontinence, urinary nocturia, getting up at night, or being incontinent of urine also. Transferring from bed to chair, are they able to get up from the bed and get to the chair by themselves, or do they require assistance, or are they wheelchair bound or bed bound? Their mobility, are they ambulating on their own, or do they require an assisted device to assist their ambulation and their mobility, a cane, a rollator, a walker, or they're holding on to the walls in their house to get around? Do they have difficulty getting up from sitting to standing? Is the gait stable? Is their balance? Are they assessing their risk for falls with this also? And ability to navigate stairs. Are they able to navigate stairs? The Lawton, which you're seeing right now, is a continuation of the same. And this is actually assessing their independent activities of daily living. And the score is, again, the higher it is, the more independent the older adult or community resident is. And there's another Lawton that you may be seeing page 1 of right now, which is broken down. So the one you saw before was more comprehensive. This is more detailed. So if you did a screening with the prior, and we noted there were deficits, then we would follow up with this one. There's a second page, which is more detailed. And these are the independent activities of daily living that we're screening for. The ability to use a telephone to initiate a call or to pick up on a call. Shopping on your own. Do you need assistance? Food preparation. Are you able to do that independently? Do you forget to turn the stove off sometimes? Housekeeping. Can you do your usual housekeeping chores, or do you require assistance with that? Can you do your own laundry? Transportation, are you still driving? Should you still be driving? This is a discussion we have with patients. We should have with patients. Sometimes a caregiver requires us to have that discussion with the patient because of the family dynamics, they don't want to bring that up. And that is our job, to assess the patient or refer the patient for assessment to see if they should still be driving. If not, we offer them, because this is an interprofessional evaluation, patient visit. So we have our social worker who will give them information and alternate means of transportation, access a ride, some insurance companies cover car service, how to get them where they need to be and not impact their independence. Because a lot of patients do not want to give up their ability to drive because they think they're giving up their independence. Are they able to schedule, lay out their medications and take it correctly? And are they able to handle their finances? So these are the independent activities of daily living. Functional independence measure, which you're seeing right now, the FIMP, again, it's a modified version, a shorter version of assessing ADLs, and it's a score of 1 to 7, 1 being low, and 7 indicating complete independence. And you could see the areas that we're assessing: self-care again, eating, grooming, bathing, which is ADLs, bowel and bladder, transferring, so it's a combination of ADLs and IADLs, transferring from bed to chair, using the bathroom, taking a shower, and again, getting around on your own, walking in a wheelchair, navigating stairs, or do you require assistance? The balance, gait, and mobility instruments are the get up and go and the time to get up and go, which are similar except one is time. So you have a patient get up, walk a straight line, turn around, and walk back towards you. If it's time, it should happen within less than 10 seconds, indicates independence and free mobility. And if it's, as you see it, the numbers go up, greater than 10 seconds, they probably require assistance. And this is another version of the same thing, the Tonetti balance and gait evaluation. This is broken down in more detail. There's a page 1 and there's a page 2. So depending on if there was a deficit identified with the time to get up and go or just to get up and go, then this would be a follow-up to that, and it would be more in-depth evaluation of the patient's balance, gait, and their ability, their functional ability. And this is page 2. The next of the 4 M's that we're going to cover as part of the comprehensive geriatric assessment is mentation. So there's cognitive and memory screening tests that we actually perform on our service. And the first is which I'm going to cover, is the mini mental status exam or state exam, is referred to differently, but still it's always the MMSE, and the clock drawing test. So the MMSE is a screening and test for memory and cognition. We ask the patients the different questions that you see here, and we score it. It's scored out of 30, 30 being high and independent, and to 0, and 0 being low. So it's 0 to 30. And we do this at every visit that the patient comes and compares it to the one before. Okay? So this is the MMSE. The clock drawing, we start out with this, just a circle and instructions. Add the numbers to the clock, add the hands to the clock, and the hands of the clock should indicate 10 after 11. Okay, so this is how the test starts out. We have it printed, we hand the patient or the community resident this with these instructions, right? And this is the scoring. So 1 to 3 is considered a high score, 3 is borderline, high score to normal, and then 4 to 6, the longer it takes to complete the task, and the scoring indicates what may be seen, what may be left off the clock, what may not be correct on the clock, and that's how it's scored. So 1 is perfect or almost perfect. The clock indicates 10 after 11. The numbers are in the correct place, in the correct sequence. 2, you see, is getting a little bit, not as perfect. And then 3, you could see from 3 going down what may be happening there. And of course, we always screen patients for depression, because undiagnosed depression could lead to so many other illnesses, factors affecting their everyday psychosocial, all of the other factors that I mentioned before as part of the geriatric assessment. Being the undiagnosed depression could actually affect that in an adverse way. So we screen our patient, and this is a geriatric 1 form. This is not but this is 1 form of a geriatric depression scale instrument. Okay. Now I'm going to review the comprehensive geriatric assessment versus a problem-focused assessment. So the comprehensive geriatric assessment and management aims to overcome some of the limitations of the problem-focused assessment. The interprofessional diagnostic process assesses an older adult's health, psychosocial, and functional capacity or ability. Develops a coordinated, integrated care and follow-up plan or healthcare goals, which is focused on the individual's needs and what matters to the patient, community resident, or their family or their caregiver. The initial assessment determines the care plan or healthcare goals based on the comprehensive assessment. It explicitly states the goals and aims of the treatment, determines the required healthcare staff or interprofessional team or discipline that's going to be included in the patient's healthcare team to obtain the treatment goals or healthcare goals, and establishes a timeline for progressive review, evaluation, reassessment, and maybe update or implementing a brand new plan or continuing the plan with updates, and continue with the care plan or development or develop a corrective plan. Another brainstorm for us as providers, which specialties, providers, clinicians should or can be included in a patient's or community resident's comprehensive geriatric assessment interprofessional team. So I mentioned before that we have different specialties that we would like to be included. On our service, as part of our grant, we have nurses, we have medical students, we have nurse practitioner students, PA students. We're going to have occupational and physical therapy students. So what combination of persons should be included in a patient's or a community resident's healthcare team, and what determines that? Who performs a comprehensive geriatric assessment? An older adult care needs can be complex and unique. The comprehensive geriatric assessment process requires a coordination to ensure the experience is positive for both the patient and their caregiver or family, and also for the provider. So a very positive relationship between the provider and the patient and their family. Any member of the interprofessional healthcare team can coordinate a comprehensive geriatric assessment. Individuals, the patient and their family trust to maintain a climate of mutual respect with open, caring interactions. It could include geriatricians, which could be MDs or DOs, psychiatrists, psychologists, as I said before, PAs, nurse practitioners, RNs, pharmacists, social worker, OT, PT, on and on. Okay. The benefits of a comprehensive geriatric assessment. It reduces mortality, improves independence, so the resident or the community resident ages in place and maintains their independence, reduces emergency hospital admissions versus the individuals receiving usual health care, the usual healthcare format that we have in place currently, improves diagnostic accuracy, decreases in-hospital care treatment complications, and facilitates effective discharge planning and less readmission, decreased admission rate. In the community setting, a comprehensive geriatric assessment reduces hospital admission, so it keeps the resident again in place, aging in place in their home and independent, decreases the risk for actual readmission of recently discharged older adults. If they don't have the supportive care once they leave the hospital, their risk of being readmitted right away increases, optimizes rehabilitation treatments to maintain mobility, and enhances health and functional outcomes. The next of our 4 M's, of the 4 M's, is what matters. Again, what matters to the patient, what matters to their caregiver, what matters to the family. And this includes culture and diversity. So here at SUNY Downstate, we have a very rich, diverse community surrounding us. And so, of course, our patient population or our community residents reflect that. So rich diversity of persons, cultures, languages, races. So we need to take that as providers into consideration and respect that as much as we can, while keeping the healthcare goals in mind and keeping the plan of care in mind. So ethnogeriatrics is the influence of ethnicity and culture on the health and well-being of older adults. Ethnogerontology is the study of aging in reference to race, national origin, and cultural practices. An individual's health is influenced by culture, language, national origin, religion, education or lack of education, income, assets, and level of acculturation. How well have they assimilated into the United States population? How well have they adapted to being in the United States versus being in their country? How much of their original culture and beliefs do they still hold on to? How do they practice as far as it relates to healthcare? Okay. Addressing these issues for the older adult immigrant requires policymakers and healthcare providers, us, to be familiar with patients' health beliefs, risk of disease, family systems and structure, access to care, and dependency on adult children. The number of foreign-born adults is increasing. So therefore, some regions of the United States, immigrants comprise a significant portion of the older adult population. So if the overall population is aging, of course, the immigrant population is also aging. The traditional comprehensive geriatric assessment provides valuable information essential to caring for older adults. However, it often fails falls short in multicultural immigration, for the multicultural immigration population. We, as providers, healthcare providers, must be sensitive to the limitations of our current assessment tools. So the assessment tools that I mentioned before, some of them are not friendly to our immigrant population, and I'll cover that in a little bit. Consider the limitations to cognitive screening tests, delirium assessments, functional and mental assessments, advanced care planning, and elder abuse assessment. So some of our instruments do not take that into consideration and therefore have limitations. Undocumented older immigrants face additional challenges beyond serious chronic illnesses and issues. Often they have poor or no access to health care. They usually present with more advanced health problems because they don't have access to health care, and sometimes they do not have the finances to pay for regular preventive medicine or regular preventive visits. Require more costly treatments because it's more advanced when it is identified, and interventions have lower cure rates. So as the disease progresses or disease is more advanced as it's identified, the cure rates are lower because it may be beyond really treating it and eradicating it. It may not be able to be treated at all. Do not receive primary preventive care because they can't afford it, or also because they're not used to having that. So they're here now, and we need to educate them that this is a requirement, because a lot of persons do not think they should go for a physical or a healthcare checkup unless they have a problem. So it will be a problem-focused visit. Preventive health is not something that they're used to having done or they could afford to have done, which results in increased healthcare costs when they present with an illness or a complaint. They are at increased risk for elder abuse just because of the stress in the family, again, the psychosocial stressors at home or what may be happening in their home or who they're living with. And immigration status and fear of deportation is a vulnerability that may be exploited. So they're persons in the community, in their neighborhoods, who, because they're immigrants, will tell them that if they don't do something, they don't pay so much, then they will be reported or they'll be deported, and so they're at risk of being abused that way. Ethno-geriatric topics necessary to optimally care for an older adult immigrant are not typically included in a comprehensive geriatric assessment. So this current format of a comprehensive geriatric assessment that we have or just discussed. Usual comprehensive geriatric assessment tools have not been validated on multicultural immigrant older adults. Completion rates of preventive health care, such as vaccines and cancer screening, is low in the older adult immigrant population. And sometimes it's actually low in the American population also, of citizen population, depending on their health literacy, their access to care, and their healthcare diversity, how much they're able to get access care where they live and be part of the preventive health and wellness screenings. Language barriers are issues for a medical visit in any group, but just think even more of an issue in patients that are from immigrant populations. The geriatric assessment should identify documents that the preferred patient, in the preferred patient population language, and strategies to address communication barriers. Another thing that's to be aware of is we do provide, I know Downstate does provide interpretation of patient education materials. We provide a Siricom translator, but there are dialects that do not translate. We aren't able to translate, and some persons from the immigrant population, older adult immigrant population, may not be able to read their primary language. So even if they're, say, Spanish speaking, and the medication label or our instructions are in Spanish, they may not be able to read Spanish. They speak it, they cannot write it or read it. So something to be aware of. So which other section of the comprehensive geriatric assessment do you think requires updates to remove barriers to optimal care of older adult immigrants? And that is the end of my presentation. Thank you so much. I hope this was informative. Thank you.